hands-on sessions, ensuring that you not only understand the tools, but also know how to apply them effectively in your work. Another exciting series we offer is Expert Exchange. This series highlights the work of nutritionists across different sectors through engaging interviews and discussions. You'll gain insights into their experiences, challenges, and successes. It's a fantastic opportunity to learn from the best in the field and be inspired by their journeys. Each episode is designed to provide you with valuable knowledge and practical advice that you can apply in your own professional practice. Aside from our Learning Hub series, our Expert Exchange series, you can expect to see other content which can include excerpts from speaking engagements, interview sessions to highlight the work that our members do in NGDI and lots more. Rest assured that we are committed to providing you with value through our YouTube page. So expect to see top-notch content. We are excited to have you join our community. Make sure to subscribe to our channel. Hit the notification bell so you never miss an update. Leave a comment, let us know what topics you would like us to cover in our regular series for future videos. Your feedback is invaluable to us. Follow us on our social media platforms at NiDST Africa for more updates and join our mission to promote healthy diets and improve public health. Thank you for watching and look forward to embarking on this journey. Hello and welcome to the Drive for Healthy Diet.
Hello everyone, can you all hear me? While we wait for the others to join, let's sit back and enjoy our intro video.
Research Associate and Coordinator of the Learning and Expert Exchange Hub at NiDST, and today I'm excited to introduce you to our mission, our work, and what you can expect from our channel. At NiDST, our mission has two key facets. First, we are committed to developing data-driven, evidence-based solutions and recommendations to inform nutrition policies and actions that foster healthy diets and improve public health outcomes. Secondly, we are dedicated to strengthening the research competencies of emerging nutrition sciences in Africa. We envision an Africa where high-quality evidence is readily available and effectively utilized to tackle nutrition challenges. Founded with a commitment to evidence-based research and community engagement, NiDST has been at the forefront of nutrition advocacy and policy development. Collaborate with stakeholders across sectors to coordinate and implement high-level nutrition research programs and initiatives. Our work spans across research, education, and policy advocacy, ensuring that we address the multifaceted challenges of nutrition and health. This we achieve through our interdisciplinary research work groups like food environment, obesity, and non-communicable diseases, pediatric nutrition, nutrition methods and technology, nutrition care process implementation, and lots more. And professional development programs, just as our Young African Nutritional Scholars, the YANS, Learning and Expert Exchange Hub, Emerging Leaders Research Grants Award, etc. Our base is in Nigeria, where we have a broad team of experts across the various geopolitical zones and in diverse areas of nutrition and the world. We are also expanded to other African countries. Our YouTube channel is an extension of our commitment to knowledge sharing, capacity building, and community engagement. Here you will find a wealth of resources designed to empower researchers, nutritionists, and anyone interested in nutrition and public health. One of our flagship series is the Learning Hub. This webinar series is aimed at equipping researchers with essential tools to enhance their research competence. Whether you're looking to master statistical software like SPSS, NVivo, or learn nutrition-specific tools, our Learning Hub series has got you covered. We bring experts to guide you through practical hands-on sessions, ensuring that you not only understand the tools, but also know how to apply them effectively in your work. Another exciting series we offer is Expert Exchange. This series highlights the work of nutritionists across different sectors through engaging interviews and discussions. You'll gain insights into their experiences, challenges, and successes. It's a fantastic opportunity to learn from the best in the field and be inspired by their journeys. Each episode is designed to provide you with valuable knowledge and practical advice that you can apply in your own professional practice. Aside from our Learning Hub series, our Expert Exchange series, you can expect to see other contents which can include excerpts from speaking engagements, interview sessions to highlight the work that our members do in NGJ and lots more. Rest assured that we are committed to providing you with value through our YouTube page. So expect to see top-notch content. We are excited to have you join our community. Make sure to subscribe to our channel. Hit the notification bell so you never miss an update. Leave a comment, let us know what topics you would like us to cover in our reference series for future videos. Your feedback is hello and welcome to Nutritional Drive for Healthy Diet.
Hello, everyone. Welcome back to day 2 of our webinar on practical applications using Nigerian dietary screening tools in research and policy. My name is Beulah, the program manager for the YANS Fellowship at NDDI Africa. Hold on a second, let me share my screen. Okay. Anyways, today, Dr. Michael, an associate professor in human health and nutrition at the University of British Columbia, Vancouver, Canada, and Dr. Batubo, a researcher and medical practitioner focused on nutritional physiology and epidemiology at the Rivers State University, will lead us through mastering the practical applications using Nigerian dietary screening tools in research and policy. At this point, I'll hand over to our facilitators to take us through today's session. Dr. Michael and Dr. Batubo, over to you.
Thank you very much. So I'm happy to lead the short introduction that Dr. Nimi and I have this morning. Then I'll pass the microphone over to Dr. Batubo for the first part of our talk today. So this is continuing on for, oh, sorry, I don't believe I've screen shared. 1 second here. There we go. Apologies. There we go. So this is day 2 of our 2-day talk. Yesterday, we talked about basically a walkthrough from the practical guidelines and the background and what prompted us to pursue the development of a clinical tool in Nigeria that aims to identify individuals at elevated risk of hypertension and inform dietary strategies to help them manage, prevent, and reduce the risk of developing hypertension. And at the end of yesterday's talk, we had demonstrated the ability of the NiDRS to accurately identify individuals with hypertension with very high accuracy, and demonstrated its proposed its act on reducing risk of hypertension by mediating lipid levels and reducing their development and their levels throughout the blood, therefore reducing risk of atherosclerosis and hypertension and so on. So that's where we left it off yesterday, but there's a lot to do yet. And the first part of today's talk is going to be the first step that we've taken in getting the NiDRS into practical application, kind of pre-implementation study that Dr. Batubo is going to walk you through. I'll then be presenting our big ideas for a national setting in order to get it rolled out, which is a large undertaking in collaboration with the Ministry of Health of Nigeria. We've been in contact with NDDI, and the idea is to work together in order to improve its generalizability and its implementation within the Nigerian health framework. Oh. There we go. So without further ado, I'll pass the baton over to Dr. Batubo to lead the first half. Thank you very much, Nimi.
All right. Good evening, everyone. Welcome to day 2 of our talk on the Nigerian Dietary Screening Tool. Okay, I'll be looking at, we are going to be looking at how useful and valuable is the tool for patients and clinicians, and look at some of the limitations that we have encountered in developing the Nigerian Dietary Screening Tool and the Nigerian Dietary Risk Score. All right. The first question that we ask ourselves in the implementation of the Nigerian Dietary Screening Tool is how useful and how valuable is this tool for patients and clinicians in Nigeria clinical setting. Now, before then, we have developed the Nigerian Dietary Screening Tool to be a 23 food group questionnaire, which has been validated, and it is reliable to be used in clinical setting. Now, based on the comments and recommendation made by healthcare professionals, we went further to simplify the Nigerian Dietary Screening Tool to a 11-item food frequency questionnaire. The aim is to ensure that it can be incorporated during consultation to provide dietary counseling to individuals that has reported or filled this questionnaire. Now, it is important to note that the 11-item Nigerian Dietary Risk Score, a 1-unit increase in the score is associated with a 2-fold increase in the risk of hypertension. Going forward, we also established that the relationship between the Nigerian Dietary Risk Score and hypertension was partially mediated by iatrogenic lipids and some inflammatory markers. After we have done that, we need to carry out implementation to see to be used in the clinical setting. So going forward, we recruited some participants, about 151 participants of patients, and then about 20 clinicians to apply this tool in routine clinical setting. Now, we conducted this study using
Are the slides working for you, Nimi?
Can you hear me?
Yeah. Did you want to change to yourself presenting slides if it's not working for you?
No, it's okay. It's working for me.
Okay.
Okay. All right. So we recruited 151 patients and then 20 clinicians for this study, and our aim is to administer this questionnaire to the patient and they will fill this questionnaire during their waiting time in the outpatient clinic and share the field questionnaire to their doctors during consultation. And the doctor will be able to interpret it and then use the evidence, the findings from the field questionnaire, which is the Nigerian Dietary Screening Tool, to provide or offer personalized dietary counseling to this patient. So we divided, the data collection was divided into three stages. First, we have what we call the pre-implementation stage, where we took their biodata, social demographic data, their medical history, and their anthropometric parameters, including their blood pressure. That was done in the pre-implementation stage. Now, in the implementation stage, what we did was to administer the questionnaire. We provided the questionnaire to the participants in the outpatient clinic. They were able to fill the questionnaire, and then they went into the consulting room with the questionnaire. Then they shared the questionnaire with the clinicians during their consultation, and it was directly interpreted based on the Nigerian Dietary Risk Score to assess their risk score. And then based on their risk score, they were advised and then counsel in their dietary habits. Now, that was done in the implementation stage. Now, at the completion of the consultation, the participants were also provided with a modified version of what we call the measurement instrument for determinants of innovation tool. We modified that tool and adjusted it for our study, which is a tool that is used to assess the implementation of any innovation that is done. Now, then we have what we call the post-implementation stage. In the post-implementation stage, what we did was we selected 20 participants for the patients and 10 participants for the clinicians, and then we have a semi-structured interview with them and then a focus group discussion. Our aim is to have an in-depth understanding and their experience on the utilization of the Nigeria screening tool and the Nigerian dietary risk score during their clinical visit. Overall, what we observed in the study is that most of the social demographic, there was no significant difference between the hypertensive group and the non-hypertensive group, except for the age, for the sex, where we have the number of female, we have more male than female. That was the only significant finding. Now, on account of the blood pressure, we observed that there are more hypertensive patients when compared to the non-hypertensive patient, as shown in the blood pressure reading, where the systolic blood pressure was 149 for the hypertensive group and 119 for the non-hypertensive group. And then we also look at the fidelity. Fidelity simply means that it refers to the determination of the extent to which the instrument was applied with respect to the strategy or the protocol in which it was developed. Now, we looked at the completion time, and we find out that during the implementation phase of this study, the completion time of the Nigerian Dietary Screening Tool was less than 6 minutes, while during the use of the Nigerian Dietary Screening Tool was less than 10 minutes with the consultation. as shown in the table in this slide. We also look at some of the feedbacks that was provided by the participants. So we look at some of the feedback, qualitative feedback that was produced by the patient. And one patient said that I was able to complete the questionnaire in just few minutes while waiting to see my doctor. This shows that the length and the time needed to complete the questionnaire, which is the Nigeria Dietary Screening Tool, it fits perfectly in the normal clinic visit. Also, another participant reported that the use of the complete form really helps my doctor to understand the food I usually eat. And I was really happy to hear the doctor telling me to reduce some of the food that I eat because it can contribute to my BP not being controlled. Now, this was a female patient that is hypertensive that reported this feedback. And this go on to show that their interaction with the doctor during their dietary counseling was effective. Then finally, on the side of the patient, another patient reported that filling the form and discussing with my doctor made me more aware of how often I eat food prepared by Mama Put and red meat each week. And the patient also added that it was an eye-opener and this will motivate me to improve my diet. For me, I will complete the form next time and come to the hospital. So this statement suggests that the patients are really satisfied when using the field Nigerian Dietary Screening Tool and for their doctor to use it to counsel them in their dietary habits. Now, we also have a discussion with the clinicians, and some of the clinicians reported that, well, it took me some time to go through the tool and understand the patient's food intake before I can start discussing it with them and advise them. But I think if the tool can be made simple and training be given on how to use it, then it will be easy to apply it without taking much time. Now, this feedback suggests that the tool, yet adequate, yet valid, there are some clinicians that still lack some nutritional knowledge to apply dietary screening tool, and training them during this utilization of this tool is very important for it to be applied perfectly. Now, another participant reported that, for me, the tool integrates well in our routine workflow, and training clinicians on how to use the tool, easily how to interpret the tool, provided some sort of dietary guidelines for each food. Now, it is important for us to understand that some of the clinicians were trained to use the tool, while some were not trained to use the tool. We are looking at the barrier and the feasibility of implementing this tool in using this. Now, if you look at the first response or first feedback of the first clinicians and that of the second clinician, you will see that the first clinician was not trained, while the second clinician was trained. And integrating it into their workflow in those that are trained was effective. That means that for the tool to be perfectly integrated, a brief nutritional training section need to be introduced for effective, or a package of how it will be used, the protocol in which it will be used to the clinicians is needed. Now, this was the implementation that we measure using the measurement instrument for determinants of innovation, NiDST. Now, what we set a standard that for the implementation, for a participant that report less than or equal to 25% of the scale items shows barriers, while above that indicates facilitators. So we look at 25% as barriers and more than 25% as facilitator. Now, we also observed that from this measurement that there was no barrier with respect to the patient. The patient, in terms of personal benefit, in terms of communication with the doctors, engagement with doctors, and their expected outcome, all were above 90%. Now, if you look at totally agreed and agreed column, you will see that they reported about almost above 90% in all. And there was none of the disagreement that was above 25%. This shows that the patients were satisfied. They supported the use of the Nigerian Dietary Screening Tool and the Nigerian Dietary Risk Score to assess their dietary intake and for their doctors to use it, because looking at the second role and the third role where we have patient communication, about 99% of the patients reported that the use of the Nigerian Dietary Screening Tool help their doctor to communicate effectively with them. And it also helped them for a better engagement with their doctors. Now, we also look at the NiDST for the clinicians. And if you look at the table that is before us, we observe that the clinicians reported 25% for nutritional knowledge and 25% for time availability, which means that the barrier to the use of the Nigerian Dietary Screening Tool is because some of the clinicians felt they do not have enough knowledge about the tool to use it and interpret the dietary assessment tool as intended, which is a barrier for the implementation of the tool or including the tool in their routine workflow. And another barrier that was reported was time constraint in using the dietary screening tool to provide personalized dietary counsel during the consultation. So those were the only barriers that were reported. But looking at the factors that facilitate the integration of this tool in the routine clinical care, we observed that the procedural clearance, which is the procedure in which the patient fill the questionnaire during the waiting time and share it with their doctors, about 100% was reported. And then the food list in the NiDST was comprehensive. When we look at the complexity, none of the clinicians reported that it was complex to be used, and then it was compatible with their clinic workflow. These are facilitators for implementation, and we observe that this facilitator helps in the integration of this tool in routine clinical consultation with their patients and the utilization. Now, like earlier on, we said that I told you that the patient completed the Nigerian Dietary Screening Tool within 6 minutes, and only less than 10 minutes was used in the consultation, where the doctors use the findings from the completed Nigerian Dietary Screening Tool to provide dietary counseling. Overall, 96% of the patients reported that the integration of the Nigerian Dietary Screening Tool, first of all, it is quick to be completed, and 90% reported self-reflection on their dietary intake after using the Nigerian Dietary Screening Tool in their consultation. About 92% also reported that they were invited for the study. This is all about the fidelity of the study. About 92% overall were invited for the study, and this 92% completed the Nigerian Dietary Screening Tool. They also shared it with their doctors, and they also offer their feedback. Now, above 80% of fidelity is acceptable in implementation study. In our study, we reported 92% of fidelity, which is above the acceptable reference value of 80%. Now, for the clinicians, we observed that 90% of the clinicians reported that the Nigerian Dietary Screening Tool have a clinical relevance, and it is also clear and complete, which is a key strength in implementation study. Above all, they reported that the use of the Nigerian Dietary Screening Tool helps them to improve their patient-clinician communication, and it gives them the opportunity to effectively engage with their patient. Although they reported about 25% with time constraint and lack of nutritional knowledge, which is the only barrier that was observed in this study. Now, overall, this study demonstrated that the Nigerian Dietary Screening Tool and the Nigerian Dietary Risk Score has a potential for integration into the current workflow, and it also enhanced patient-clinician communication. Now, what have we learned so far? The study provided some evidence that patients and clinicians have a positive experience with the use of the Nigerian Dietary Screening Tool. This significantly enhanced the patient-clinician engagement and communication. Although some barriers were recognized, and this has to do with the use of the tool in a single hospital setting. Again, the integration of this tool into routine care could also enhance, one, dietary consultation, two, support the prevention and management of hypertension by using it to identify the individual that are at risk of hypertension. Therefore, it offers a solid foundation for further study that aim at optimizing and personalizing the Nigerian Dietary Screening Tool in other regions of Nigeria. Now, we have some limitation for the Nigerian Dietary Risk Score. First of all, it was constructed and validated in a single clinic at the Rivers State University Teaching Hospital, Rivers State, Nigeria. Although we understand that there could be cultural variation, dietary pattern, behavior, and environmental changes across Nigeria. However, one thing that we observed in our study was that the three major ethnic groups in Nigeria were represented in this study. Also, to evaluation of the feasibility in a single urban clinic with respect to direct access to expert research, which is a single researcher that conducted the study. And then their usability across Nigeria clinics in both rural and urban setting has not been fully investigated. Now, only evaluated for this Nigeria Dietary Screening Tool was only evaluated for adult onset hypertension, whereby we know that there are other high-risk populations that also are risks of hypertension. For example, gestational hypertension or chronic hypertension in other chronic conditions were not assessed. So going forward, these are the limitations that we aim to address in our future studies. So at this point, I will hand over the mic to Dr. Mike to continue with the presentation. Thank you all.
Thank you very much, Dr. Nimi. Really appreciate it. And you summarized our work ahead very nicely, and actually highlighted a lot of the key points that drove our plans going forward. So we have faith that the NiDRS in its current form, which was well received overall by clinicians and patients, will be translatable across other areas of Nigeria, but we really don't know that for sure. And there is a high likelihood that by making certain modifications, adjustments, bringing in and addressing other features within the questionnaire or the risk score, I should say, we could improve it further and make it more amenable, usable, and valuable across all regions of Nigeria. So the next step is all about kind of tackling those overarching questions that we are relatively confident we will do well in, particularly with the support that we've garnered. But we do need to evaluate the generalizability across Nigeria outside of the one region and clinic that we were working in. We need expert input and support. So we have support from the government of Nigeria, the Ministry of Health. We've received support from NDDI, and we have support from individuals, registered dietitians and clinicians in a couple areas in Nigeria where we have some contacts already. And the whole aim is to identify any existing barriers, whether they have to do with the questionnaire itself, whether they're administrative, whether they have to do with the health system, that need to be overcome or appreciated or adapted in some way in order to actually get this tool implemented and embedded within clinical care across Nigeria. So there are a lot of things that we have to work on. In addition, this is a long-term approach that we have planned. Dr. Batubo and myself, we are really passionate about getting this sorted, but we, and myself included, we can't be on the ground all the time, and the best people to lead it are the individuals, the researchers, the health professionals in Nigeria. So we need to make sure that we can pass that baton down the line so it can be looked after appropriately within that region. So that's what I'm going to be talking about next. And the study, the acronym that we've have for that, and the study idea is called the Unity Project. So it's using nutrition education to initiate early clinician-patient dialogue on hypertension in Nigeria. So it's a very large proposal that we've put forth. It has individuals who have experts in global health in the UK, in Canada and in Nigeria, and dual citizens. And the aim is simply to, as I said, appreciate the generalizability and what needs to be done at all these different levels, which I'll walk us through shortly, in order to make the NiDRS as easy to implement and as valuable and useful to implement as possible. Now, we've already talked about how through the pre-implementation study that we did, that Dr. Batubo just walked us all through, had a relatively diverse population with 3 ethnic groups. That gives us some confidence, but we can't be naive either. There are over 230 million people in Nigeria, all divided across 6 geopolitical zones that differ in their geography, their ethnic group, political history, diet, food patterns, ethnic groups, living conditions, socioeconomic status, all these factors. And all these factors, whether directly or indirectly, are going to impact how diet and also the foods that are going to drive and mediate hypertension within these regions. And with that, we also see a variation in the prevalence of hypertension across these regions, varying from 34% to 61%. And it may be in certain regions that diet is more important than in other regions. And in other regions, perhaps through our discussions with all these professionals, health professionals, ministry, NDDI, that we will start to acknowledge maybe we need to include some other factors in our assessment, perhaps sedentary time, perhaps physical activity, family history. And we will create a revised NiDRS that captures these so that we can much more, with greater confidence, roll out the NiDRS to all these regions and ensure its equitable value across these regions. Going back to diet, and this is, of course, the primary role of the NiDRS, is to be able to characterize someone's hypertension risk based on the foods that they're consuming. And already we're seeing there are very different prevalences in the quantity of foods that people are consuming across these regions. Looking at cereals and other cereals, for example, we see in the Northwest, it contributes a much higher proportion to their diet. And in the Southwest, we see that a lot of kind of meals and snacks consumed out are more common in the Southwest than they are in other regions such as the Southeast. So how this changes and whether it's requires modification to the NiDRS to perhaps reweigh some of these factors as they contribute to the foods that are being consumed, we don't know. And that's something that we simply have to look at so that when we roll it out, we get it right the first time instead of having to go back and do it again and lose confidence from patients, health professionals, and the ministry. We want to cover all of our bases the first time around. So these are all factors that need to be considered for sure. Another thing that came up as Dr. Batubo was talking about, and this is a big part of the Unity project, is we saw that there was this gap in knowledge, either reported by the clinicians themselves or a gap in knowing what to do with the results once they have them. So a big part of the Unity project is its diversity. We have a range of different sexes and genders and different geographical individuals from different geographic regions, different levels of expertise across implementation, epidemiology, health sciences, medicine. And we also have 3 out of the 9 individuals are registered dietitians, and we know the role that they're going to play. And I was reading the comments the other day. I saw a lot of the passion in order to ensure that dietitians are included in the NiDRS, and that's something that we've acknowledged, that we've gotten in the feedback, and we know it has to be incorporated. So when we finally have the NiDRS rolled out and are talking with the ministry, with the dietitians that we have already and those that we collect through the NDDI that come on board in order to help us at all these get-togethers and meetings that we've proposed, it'll be really important to find the algorithm and that pathway whereby the patient completes the NiDRS, they talk to their clinician, and then based on the feedback required, perhaps if it's fairly straightforward and simple, the clinician will be able to deliver the advice. If not, at that point, they'll go directly to the dietitian, or perhaps, and this is certainly all for discussion as soon as we're all sitting around that table, we'll find alternative ways where the patient goes directly to the dietitian for their feedback and guidance. But we need to find the best strategy that works for the patient and that works for the Nigerian framework in order to get the maximum benefit without burdening costs in any way, of course. There's always that balance that we have to keep in mind, which is why we need everyone around the table. So currently, we know the NiDRS quantifies dietary mediators of hypertension risk. We know that it correlates with mean arterial pressure, all sorts of cardiovascular disease biomarker, and that makes it very, very accurate in predicting hypertension, and it gives us a lot of confidence that it is actually predicting hypertension risk and not other mediating factors or confounders that pass along with it. And we've also seen from the feedback that it facilitates patient clinical dietary education, which was favorable both from the patient side and the health professional side. So we're feeling very good about this, and we've gotten the encouragement from all the included parties that we've discussed so far in order to talk about implementation with Nigeria's Ministry of Health. And that's what we've gone and we've been doing. So we have our support from them. We've been in touch with NDDI, and we're moving forward in order to get this going. So we've already submitted it once. It wasn't accepted the first time, but we've received some very valuable feedback, very favorable feedback and support from the reviewers of this grant, and we're working on improving it for the next submission so we can get it going. But I think it would be really nice in order to go through the steps that we have, kind of the practical guidelines, the practical experience of putting this all together and having a good understanding of how you get something like the NiDRS or any sort of clinical tool, whether it's dietary or something else, and actually get it embedded and implemented within a health framework. In this case, it's certainly the Nigerian health framework, but it would be very much the same, simply different parties, different government, different groups that you're talking to. So the first part is very much the operationalization of the NiDRS. So right now we have one tool, the NiDRS, that has been validated and optimized for delivery by Dr. Batubo in a single clinical setting. But we don't know, excuse me, what barriers there may be beyond that in order to roll this tool out to other clinics within Nigeria. There may be some administrative barriers, some important feedback that we need to bring in. So we'll be chatting with all sorts of people there in order to get kind of that upper level preliminary feedback from all parties involved. And I'll walk through these steps in a little bit more detail over the next few slides. Once we have a revised NiDRS that's essentially signed off by all included parties, then we'll have to revalidate it and test its operationalization across Nigeria. And then the third part, the important part, but somewhat separate, is leading research capacity upscaling for health research in Nigeria. So right now it's Dr. Batubo and myself that are leading it. We're very passionate about it, but we can't be leading it all the time. And the best people to lead it are certainly more individuals across Nigeria who have that hands-on expertise in order to lead it, maintain it, and improve it across Nigeria. We see this tool, excuse me, being extremely valuable for hypertension, but there are a number of cardiometabolic diseases that are impacting Nigeria and other West African nations and countries across the world. So perhaps it can be modified or adapted or revised in order to prevent other forms of cardiovascular disease or type 2 diabetes or obesity that are also impacting health in Nigeria for sure. And that would be a great strategy in order for these individuals and these groups that are empowered and trained or to take over for Dr. Batubo and I in order to lead the development and ongoing research for the NiDRS and clinical health research in Nigeria. So the way this grant has been broken down is into 3 work packages or 3 distinct aims that go in that area. Aim 1 is what happens first. We talk to the individuals and the organizations that are kind of working in the background, but ultimately in charge of this health framework, and bring them together with the people who are on the ground in order to ensure that there's as much agreement as possible between them in order to get this tool on the ground. Aim 2 is going to be essentially replicating what Nimi did, Dr. Nimi was presenting in his last talk, his last part of his talk. And then the last part is very much about empowering people and ensuring that they have all the skills that they need to take over for Dr. Batubo and I and manage it for the long run. So aim 1 we see is a group of diverse individuals who are going to be coming together. So this will be facilitated by the individuals on the grant who we already have, as well as invitations to government officials who we've been in contact with. We have their letters of support to attend and provide feedback. We have the policymakers and we have health providers. And I want you to be aware that when I'm saying health providers, I'm certainly not just talking about clinicians in this case. It's certainly going to include clinicians, but it's also going to be dietitians and nurses. And we're also aware that we are going to be actively recruiting and inviting individuals from across Nigeria, and also not just individuals in urban settings where we were previously doing our work, but certainly in urban and more remote places as well, to make sure that however this tool is rolled out, whether it's in an online platform, a digital platform, or a paper platform, or some sort of hybrid, it's usable and valuable to everyone. So at this point, there'll be focus group interviews and consensus meetings in order to get everyone's feedback on things that need to be improved, potential barriers and feedback in order to improve it, get a really good understanding of where the NiDRS can fit into the mapping of an individual's health and progression towards hypertension and what is currently done in order to manage it. So where really the NiDRS fits in it and who are going to be the parties involved and at what point will they be involved in that person's treatment. As I said, this is going to be some of the early talks where we find out where clinicians will be, where dietitians will be, where nurses will be. I'm sure there'll be some very interesting discussions. And in the end, we'll get the best way possible so that the patients get the best benefit and the individuals and all those involved will get it at the right point that works within the existing framework. Once we have the feedback from all of those parties, we will then consolidate it. We will offer revisions on the NiDRS. We'll make our own revisions. And what we'll do actually at the end of that kind of output stage is we'll go back to the patients across Nigeria. We'll have a recruitment strategy on Facebook, on all these different platforms. And we'll actually try and get regional feedback from patients across Nigeria to see how they feel about these changes that are being done and the revised NiDRS. So they still find it very simple when they're trying to complete it. Is it still short and easy? Do they have concerns about the foods, the diets, anything that's missing or any gaps that we haven't been able to pick up over our focus studies in the South? And wasn't picked up by health professionals as they didn't have their patients hat on. They had their health professionals hat on when they were reviewing the NiDRS the first time. Additionally, during this time period, we have some capacity building opportunities that have already been identified, but through these consensus meetings and group interviews, I think that'll allow us to identify groups and areas of capacity building and research expertise and research analysis and ongoing analysis where we could perhaps identify and help grow these areas a little bit more so that they can then take over once the study is ended. So the first part is really about getting the sign off and removing as many kind of low-hanging barriers that we can see, and all these policymakers, government officials, and health professionals can see at this time point, to make a revised NiDRS 2.0 that is ready to be rolled out and tested across Nigeria. And that's what AIM-2 is. And again, it's basically replicating what Dr. Batubo was presenting in his previous aspect of his talk. But this time, instead of going to just one clinic within one hospital, we're going to be rolling out to 24 clinics across Nigeria rather than just that one, with 12 clinics in urban settings and 12 clinics in rural settings. So using this new revised NiDRS 2.0, we are going to be assigning it to, or offering it to patients to then share with their health professional. We will, at that point, ideally in clinics that have registered dietitians on hand, particularly in the urban areas where they're likely to be in higher prevalence and easier accessibility. We'll start to bring them in now based on the feedback and the suggested framework that was developed in AIM-1. And we'll start to really get an idea of how that algorithm or the pathways that were suggested in AIM-1 are, how effective they are across Nigeria. And then based on the qualitative and the quantitative feedback that we gain from patients and the health providers, excuse me, and again, that includes not just the clinicians, but the nurses, the dietitians, and anyone else who's involved at this level in delivering healthcare to individuals, how they feel about the current strategy and the guidelines and the framework that we've developed, and how we can further improve it, certainly. So at this point, at the end of AIM-2, we will have feedback based on regional expertise, regional expectations from patients and health professionals. We will have feedback from urban and rural settings. We will have an understanding, just as Dr. Batubo presented in his previous slides, how accurately and how effectively the revised NiDRS associates with hypertension, with blood pressure, and with biomarkers of cardiovascular disease across regions of Nigeria. So that will give us the confidence that we need, and indeed the government of Nigeria, the health ministers, in order to have faith and data-driven confidence that the NiDRS in its current state is ready and valuable enough and beneficial enough in order to be rolled out across Nigeria. Now, we do expect some further modifications, certainly, from all the different regions, and we'll bring them all together. And where there is consensus across the board or a majority vote, there will certainly be further modifications to the NiDRS. So there'll be a revised NiDRS version 3 by the end of AIM-2, most certainly. Now, the other aspect, and a lot of this will start to come in AIM-1. So this is all about improving the implementation research and health research capacity in order to follow through and carry forward with the NiDRS after this grant is completed. So I should bring up that this grant has a timeline maximum of 5 years. That certainly doesn't mean Dr. Batubo and myself will be running away and hiding away after those 5 years. But we do hope that after that, we can start to take a slightly more of a back seat and let the individuals in Nigeria, which really lead these skill sets, and continue with the optimization and driving this health research forward and improving the NiDRS further for perhaps other outcomes, like I mentioned, diabetes, other factors of cardiovascular disease. So in order to get that going, we have proposed recruiting all sorts of graduate students, early career researchers, postdoctoral fellows, government officials, policymakers, and getting their understanding and where they feel they have gaps in research and understanding in order to carry forward with this work. So where there are gaps in either government research, health research, university research, and it's certainly not that we have all the answers, but once we identify them, we could bring new people in order to support those areas. So from there, we'll look at developing new curriculums, online courses, handouts, sheets. I heard questions about training courses previously on who will be teaching the NiDRS, on how to implement it, how to use it, how to work with it. These will all be undertaken within these courses so that once we're completed with AIM 3, we know not only how the NiDRS needs to be presented and trained on so that individuals know how to use it effectively within the health system, but also how it can be monitored and improved down the road. So there's a lot of areas that really need to be covered, where there's all sorts of work that can be done, certainly. So that's where the curriculum development comes in. Just out of sheer interest and curiosity, I think we can all gain from having increased skills in data analysis, whether it's quantitative or qualitative. So throughout this course, based on the postdoctoral fellows, early career researchers, and graduate students that are involved in this study, we'll host open data analysis classes to provide training in all these areas. And then, of course, there'll be all sorts of mentorship across diverse groups. So right now, everything is being led through the region in Rivers State. But if we include more individuals with expertise across Nigeria, differences in ethnicity, sex, area of residence, and even country of residence, I think that'll only add to the expertise and range of feedback that we can get when we're improving the NiDRS and bringing it forward for implementation. So the outputs that we hope to generate from this are what's known as MOOC, a massive open online courses where individuals, whether they're health professionals or patients, and we could have certainly specialized ones, could sign in and learn about the NiDRS, what can be done, what can't be done with it, its limitations, how it will be implemented, and how it can be integrated into a clinical setting in order to help patients. And then, of course, we'll integrate also that framework of who the individuals will be discussing the patient's feedback with and in what order. Based on capacity building, we'll certainly be working with all sorts of early career researchers, graduate students, postdoctoral fellows to certainly help take over as this grant comes to a closure. We'll be working closely with management and health government officials in order to keep those lines of communication open and constant feedback for improving the NiDRS. And also, being that AIM 2 is going to be going to 24 clinics across Nigeria, urban and rural, I think it'll be a fascinating way in order to start a national data bank of dietary and health metrics across Nigeria, so that down the road, following implementation, perhaps we can roll up to some of these clinics again, repeat some of these assessments and see how health is improving across Nigeria. And perhaps in doing so, identify even new and novel areas of focus in order to improve health across Nigeria. So the outcomes that we're going to pick up once we bring AIMS 1, 2, and 3 together is going to be the revised NiDRS, a version 3, really. We'll have a roadmap for future implementation. Where do we start? How quickly it comes out? Which clinics are going to start out with it? And in order to kind of get that nice gradual but confidence building experience working with the NiDRS to reduce hypertension. And then we'll certainly have that curriculum, that capacity building that we talked about with online and in-person nutrition education, and then certainly training sessions on how to use the NiDRS in a clinical setting. I think the patients will benefit from it because they'll have this Nigerian-informed tailored clinical tool, which was lacking just 4 years ago when Dr. Batubo and I started, and they'll all benefit from more personalized clinical nutrition education, which, although in many cases, I think the feedback will be largely similar in some ways, reducing the salt, reducing the high fat. I think being able to really provide personalized guidance on which foods within these individuals' diets will have a much more meaningful and a larger impact than just giving general feedback. There's also, without question, patients who know that their personal understanding and their personal diet has been considered. There's evidence showing that their adherence and their commitment to improving their diet is significantly greater than just general feedback on a pamphlet given to everyone. On a community level, and by that I mean within the clinic, within the GPZ, and across Nigeria, we'll have mentorship for future nutrition and health researchers and leaders of the NiDRS well into the future. And it'll certainly open the door for follow-on studies that go on to further improve the NiDRS and to perhaps develop new and improved NiDRSs for other health outcomes of interest in Nigeria. So long-term, we hope to improve the concerted efforts and the communication between the government stakeholders, the health professionals, and patients across Nigeria through leading this implementation study. The big one is certainly to improve nutrition education for hypertension prevention across Nigeria and hypertension management. And we do think, although not targeted for other cardiometabolic diseases, there should be a knock-on effect whereby if you're improving someone's diet, you are likely to reduce the risk of obesity and diabetes down the road as well. We'll have the start of some very powerful nutritional tools that could lead to future initiatives, both in Nigeria and perhaps other neighboring West African countries, so further collaboration there. We'll have the development and expansion of study health records by starting with AIM2 and visiting all these clinics across Nigeria and collecting patient data across Nigeria. There is the opportunity to start monitoring and very closely monitoring, getting an idea of how diet is improving, how health is improving, and where new focus for health outcomes and health concerns should be targeted on, whether it be across Nigeria or within specific regions. And in doing so, with the curriculum development, with working with everyone, and with the capacity building exercise, we hope to really pass the torch on to future leaders in governments, policy offices, research, and clinical practices to take over and lead the development and the execution and the ongoing optimization of NiDRS across Nigeria and potentially the rest of West Africa. So it's a very big study. We have a lot of people involved, but I think the outcome and the ultimate aims, both kind of shorter term and longer term, are certainly worthwhile, and it's something that Dr. Batubo and myself are full-heartedly committed to, and we're very happy and proud, actually, to have garnered the support of the Ministry of Health and NDDI in making this happen. So, to very quickly summarize, we want to increase the awareness and use of the NiDRS for future education in clinics across Nigeria, improve patient awareness across Nigeria of the link between nutrition, health, and disease, prevention, and management, how closely they are related together. We want to develop online courses, these massive open online courses for individuals in Nigeria of any health professional to learn about the NiDRS, its limitations, and how it will be how it will be integrated in the pathway of treatment for patients who complete the NiDRS based on their scores and perhaps the severity and comorbidities that the individual carries. Long term, we believe that the NiDRS will lead to national improvement of diet and reduce incidence of hypertension and potentially other cardiometabolic diseases that are also associated with diet. And equally exciting, and certainly from a future research and advancing health in Nigeria, longitudinal collection and monitoring of health, diet, and cardiometabolic statistics across Nigeria is only going to bring further benefit and health research improvement across Nigeria in the future. So with that, we have covered how we plan to evaluate and improve the generalizability, how and whom we are seeking for expert advice and input and support in order to improve and further develop the NiDRS for rollout across Nigeria, how we aim to minimize barriers to improve its implementation, and our plans to support and kind of facilitate ongoing research in order to reduce long-term barriers and any remaining gaps and limitations that we weren't able to address and weren't flagged for us in this study. Future facilitators and researchers can address those and improve and redesign the NIDRS for long-term health improvement. With that in mind, I'm going to pass the baton back to Dr. Batubo, I believe, in order to talk about gestational hypertension. Or Nimi, remind me if I was supposed to be talking about this.
You're supposed to be talking about it.
I am supposed to be talking about it. Okay, completely fine. Okay, thank you. So another area of interest for me, and this one certainly hits a bit closer to home for me, is my area of research interest before Dr. Batubo came along was health in pregnancy and how it impacts the mother's health long term and how it impacts the offspring's health, both during gestation, at delivery, and long-term risk of obesity and cardiometabolic diseases such as diabetes and cardiovascular disease. So a growing area of interest for me, in that we have only studied this in non-pregnant men and women, adults in Nigeria, is how effective and beneficial the NIDRS can be in a perinatal setting. So gestational hypertension is the development of elevated blood pressure after 20 weeks of pregnancy. It's a major risk factor for preterm delivery, low birth weight, adolescent onset obesity, and a marker of preeclampsia. And unfortunately, like hypertension itself, adult onset hypertension, gestational hypertension affects almost 1 in 3 pregnancies in Nigeria, which is a huge, huge number. If you think about the number of women who have repeat pregnancies, that means that even if someone doesn't have gestational hypertension in their first pregnancy, they have a very high likelihood of 33% chance of having it in their next pregnancy. So without question, there's a lot of women who are experiencing or who are likely to experience gestational hypertension in one of their pregnancies. So it's a major area of interest. It's a major health concern, and it's one that's come to our attention and we're starting to work on a little bit more closely. And what we see in Nigeria, again, it has one of the highest incidence of gestational hypertension. It has one of the highest growth rates, and unfortunately, one of the highest death rates due to gestational hypertension around the world. And although 1% may not seem like that much, the incidence of gestational hypertension is increasing in Nigeria by 1% every year. So from year to year, it may not seem like that much of a difference, but unless we step in and do something now, in 10 years, there's going to be a 10% higher incidence rate of gestational hypertension in Nigeria. So it's a problem that is already a problem, but it's only going to get worse unless we can find something to do about it. And that's where certainly the NIDRS comes into play. Now, although we don't have hands-on evidence from ourselves or from other researchers directly in Nigeria, neighboring sub-Saharan countries have demonstrated that dietary education itself, so this is not even going on to measure if the individuals have changed their dietary habits, which they likely have, but it's something that these researchers hadn't directly. They simply looked at the delivery of dietary education or not in randomized control trials. And they found that those pregnant individuals who were offered dietary education and randomized dietary education actually reduced their odds of gestational hypertension by 75%, which is a huge reduction. And if you can just imagine having that same impact or even a greater impact in Nigeria, that would be phenomenal. Now, unfortunately, just like we have with adult onset hypertension, culturally appropriate tools and resources in a clinical setting do not currently exist in Nigeria. So it's a lot of the same problems that we have, but thankfully we're starting at a much better place in that we already have the NiDRS to start from. We don't have to start from scratch again. So what we need to know, though, is can and how effectively the NiDRS can help in a dietary education setting, in a clinical setting, in antenatal care, in order to assess diet in early pregnancy or even pre-pregnancy at the family planning stage. And if we could get it integrated in, we could fill that gap that is currently a really critical missed opportunity that hopefully the NiDRS can step in and fill. Now, the study itself is, again, we already have the NiDRS in its current version, so we just need to start with a very sort of basic and small pilot study, as we did in the early stages of the NiDRS. So the plans are relatively straightforward. We work in a clinical setting. We will recruit women in early pregnancy before 20 weeks of gestation, and they will be randomly assigned to either follow normal or standard clinical practice, clinical guidelines. We will then monitor them throughout pregnancy. We will evaluate and quantify the incidence of hypertension and blood pressure, both at pre-20 weeks pregnancy, at 20 weeks pregnancy, and at delivery. And then we'll also early on at delivery capture information related to maternal mortality, preeclampsia, gestational age at birth, so preterm birth if it's less than 37 weeks. And if possible, for down the road follow-up studies, weight gain in offspring to see if they're at more likelihood to develop obesity in early age. The other half, the other randomized control group, would be presented with the NiDRS and then share it with their antenatal clinic health professionals. We will then certainly monitor them for the duration. We anticipate that mothers who are randomized to the NiDRS group will have offspring who grow at more normal rate. They are born to later gestation, so full term after 37 weeks. Their offspring at birth and in early offspring and early age will be less susceptible to overweight. There will be less likelihood of mortality and preeclampsia and preterm birth. So overall, if we can demonstrate this, it would suggest that the NiDRS will certainly improve the health of the mother by reducing her immediate risk in pregnancy, but it'll also have a knock-on effect by improving the health outcomes for the offspring, both at birth, by increasing the likelihood of a full-term pregnancy, and increasing their health even in early age, where we know that offspring born to mothers who develop gestational hypertension are more likely to be obese by adolescent state already. So that is the ultimate aim that we have going forward as another population that we're going to work with in Nigeria who are just as much needing structural care for dietary education as adult onset individuals are. So with that, for day 2, we've looked at how useful and valuable the tool is for patients. We looked at the current limitations of the NiDST and the NiDRS. We walked you through our plans on bringing groups together in order to improve the generalizability, gain expert input and support for its implementation, addressing long-term barriers, which will undoubtedly happen, and perhaps more will certainly pop up that we'll have to address as this goes forward. And indeed expanding the generalizability of the NiDRS further, not only across Nigeria, but to other high-risk populations in Nigeria and potentially other West African nations as well. So take-home messages is that the NiDRS in its current state within a clinical setting, a single clinical setting, is a validated, reliable, and user-friendly tool for clinicians and patients. Clinicians appreciate its ease of use, its speed, its accuracy, and patients really like that it helps give them some direction and how to inform their discussions with health professionals. Given the diverse population that we had in our studies, we have a high level of confidence in its usability and value in other Nigerian regions, but we do require validation across regions in order to demonstrate this. And the major way we're going to go about doing that is through the study I just presented to you, the Unity study, where we bring in experts from across Nigeria to weigh in and tell us the best way forward of getting this tool within the Nigerian health framework. And then ultimately, we feel the NiDRS will lead to improvements in hypertension and other cardiovascular and cardiomorbidity concerns in Nigeria, and certainly future neighboring countries once we have it right. I think other nations and regions will also find it of interest and be knocking on doors in order to collaborate with the individuals who are involved in this long-term settings in Nigeria. On that note, it concludes the talk by Dr. Batubo and myself. We thank all of you for your time. We thank the commitment and the support that Dr. Batubo and I have received from colleagues and researchers and health professionals and support workers in Nigeria, our collaborators in the UK, all doctors and nurses, certainly the patients, and undoubtedly the Federal Ministry of Health in Nigeria, and most certainly NDDI for inviting us today and supporting this ongoing research that we have going on. And we look forward to any questions that you may have. Thank you.
Thank you, Dr. Batubo and Dr. Michael, for the amazing presentation. Please let's react by clapping or yes. We'll begin the question and answer session right now. Please submit your questions and they'll be answered accordingly. So for our first question, how can we get this tool and how can we be trained?
So the tool that's a great question. So the tool, and I think some of it's already been answered in the Unity talk that I just had. So the tool is readily available. It was published in our most recent publication. I just put the link in the chat. If you go to the supplementary material of that paper, it's all there. So you can look at the NiDST and the NiDRS. For using it, you are certainly welcome to review it, but again, based on the plans for the Unity project and our lack of confidence, sorry, not our lack of confidence, our lack of evidence that it is translatable and generalizable across Nigeria, I would ask you to use it with caution and respect that it may not be perfect in regions used outside of River State at this moment. It still needs to be validated outside of it. Further, Dr. Batubo was doing all the training on it previously. So there may be something to do with his method of training, whereby if you just use the NiDRS without having that training and understanding, there may be something missed in its interpretation and use. So certainly please look at it, review it, and test it out with colleagues. We would love your feedback, but I would say use it with caution at this point in time.
Thank you, Dr. Michael. We can see a lot of comments about integrating dietitians. While I think you have mentioned the generalized plan, is there anything else you can add since the long-term goal is to increase nutrition education on nutrition education for people with hypertension?
I'm not sure really. That's kind of it. We've developed this tool from an apparent gap that Dr. Batubo noted. We've taken it from the ground up, and now we're at that point where we don't know where the limitations are within the Nigerian health framework and where the best place to position it is. So we know from our perspective and the individuals that I work with and have worked with in Canada and the UK and throughout the US that we do need all health professionals involved in order to make it a reality and as valuable as possible. So that's why we are certainly trying to get everyone involved. So not just clinicians, but certainly registered dietitians and nurses and health professionals in general. So wherever there are current gaps, if they are brought up through these unity meetings that we have planned across Nigeria with all sorts of health professionals and patients, I'm hoping they'll come to light there and we can try to resolve them. But there are going to be a number of gaps that still need to be filled in order to get this within the Nigerian health framework. I'm not sure if I answered that question to its fullest, but it was a really big question, and I don't know if I could have completely answered it all in this time frame.
Okay, thank you very much. So hypertension is the main concern in this presentation. Is there any justification for this?
Sorry, can you just?
We have another question. Saying hypertension is the main concern in the presentation. Is there any justification for this? So someone is asking if you can justify why only why the tool is used for only hypertensive patients.
Fair enough. So that was essentially a starting point. So hypertension, if we look at data records, if we go to the WHO or the Nigerian Ministry of Health guidelines, hypertension is often listed as the major driver of severe cardiovascular disease and the disproportionate driver of the high incidence in Nigeria. So the reason we started with hypertension is simply because of that. It seemed like the greatest health concern in Nigeria at this time, one that's clinically diagnosable, straightforward, and it seemed like the best place to start. But I do full-heartedly agree that there are other health concerns related to hypertension, and I feel that by bringing in the NiDRS, and particularly by doing this long-term research across across clinics and regions in Nigeria, we could really start to appreciate how it improves other cardiometabolic health concerns that are associated with diet for sure.
Thank you very much. The NIDR tool is currently only made for clinicians and for the hospitals. Is there any other way for this tool to break into the community setting so that people in academia or researchers can also use this tool in their studies?
I certainly hope so. Yes, without question. Researchers are certainly more than welcome to use it. Again, because it's not been validated across all the regions of Nigeria, we don't want to recommend it be used in a clinical setting just yet, out of fear that it may not be optimized yet and then not live up to what we saw in our examinations and in our research, whereby if you wait till after the Unity study is done, it should be equitably effective and valuable and useful across Nigeria. But certainly, again, if you follow the link that I posted in the chat, you're welcome to use it, review it, access it. We just obviously ask to be referenced. If it's for any research, we can provide feedback, and we're happy to work with people going forward. And then through the Unity study, I full-heartedly agree. I think access to healthcare varies greatly depending on whether you're in Canada or the UK, Nigeria, or other nations. There are all sorts of ways in order to gain feedback on someone's health And just reading through some of the points here, you're right. Someone mentioned that I keep using the word dietitian, but there are nutritionists who maybe can also use this tool. They can certainly also be involved in the Unity study as we get in touch with NDDI to create these meetings and get them populated with individuals involved. I think we could look at kinesiologists, sieving, nurses, health professionals, any health providers throughout Nigeria, really, if they're involved in some way through the Nigerian health framework, then they will certainly be invited to attend these talks and these meetings. And if not, if they can't be involved at that stage, when the Unity study is done and the new paper is published with the revised NIDRS 3.0, we will have higher confidence in its validity and its usability and its value across Nigeria. So at that point, it'll be open access, and most certainly anyone will be able to use it, get access to the paper, and then anyone should be able to attend those massive online open courses that we'll be creating for any health professional or health individual to learn how to use the NIDRS and interpret it.
Thank you very much. Please don't forget to put in your questions in the comment section. They will be answered accordingly. Also, we are encouraged to provide feedback about the webinar while we continue to ask questions and get feedback from our facilitators. So we have a follow-up question on the academia, and someone is trying to know if there's any way for academicians to help this milestone to become a reality. Is there any way they can contribute to, developing the NIDR tool 2.0 or 3.0?
Certainly. I'm just going to ask is if Dr. Batubo wants to come back on and answer any of these, he's certainly welcome to. I'm happy to answer this question without hesitation. Academics are most certainly welcome. Again, this will have health policy makers, epidemiologists, individuals within the room when we're having these focus groups, but we'll also have graduate students, postdoctoral fellows, training sessions on quantitative analysis, and individuals who are interested in contributing either through those training sessions, supporting grad students, or getting involved at any time point. I welcome them and invite them to contact myself or Dr. Batubo in order to get the Unity study going and offer their support in any way possible. We really are eager to get as much support as possible. The more support we have, the more confident the funding agency will be in that we have the full backing of individuals in Nigeria, and the tool has been indeed designed for them, and it is of interest to them.
Thank you very much. We have another question. Someone is asking if the NIDR tool is the same as food frequency questionnaire used by dietitians.
Is it the same? Well, in concept, the NiDST is very similar to a food frequency questionnaire. Yes, I would say the primary differences between it is that it's much shorter because it's simply 22 or 26 questions, whereas food frequency questionnaires can be certainly much longer. And it's also not semi-quantitative, so we're not actually asking on the serving sizes. We're simply looking at frequency of consumption. And that was it was a very important decision that we made early on. And through our analysis, we found that just understanding the foods individuals were consuming and the diversity of their diet, not necessarily the proportions and the quantity of these foods they were consuming, that in itself was a strong predictor of hypertension, which we demonstrated upwards of 85 and 90%. So those would be the primary differences between the NIDRS-T and a standard food frequency questionnaire.
Thank you. I think I skipped a question. So someone was asking, considering high populated areas, there's very few doctors on site, will the use of the tool be effective and be sustainable?
That's the big questions that we have for the Unity project. You're absolutely right. Where this tool was developed, it was done in a region that had accessibility. The patients had doctors. They were visiting the outpatient clinic. it was all very straightforward. But that's part of the issue that we have going forward. There are individuals with less accessibility to clinicians and health professionals. So how can we provide them with access to the NIDRS and with guidance on improving their diet? And one of those ways may be through online meetings, personal accessibility, self-training on the NIDRS is an option. If the massive online tool course is accessible to everyone, then perhaps we can have representatives in regions or areas or individuals are teaching themselves and evaluating their families' current health status and advising their clinical guidelines there as well. So there are certainly gaps, and those are big ones that we want to address going forward. But that's one of the reasons we're trying to keep the tool as simple and understandable as possible without compromising its value and its accuracy in predicting hypertension and associating with cardiovascular disease biomarkers.
Thank you so much, Dr. Michael. Please don't forget to submit your questions. Also provide feedback about the webinar. This is our last webinar for the year. And so please check your emails, because emails will be sent for participants to share feedback about all the webinars that have been conducted this year. We have one more question. What is the difference between NIDRS and NiDST?
That's a really good question, because I think it's one that I fluffed up a bit during my talk. I referred to it prematurely as the NIDRS, and I think that brought some confusion along with it. So the NiDST, or the Nigerian Dietary Screening Tool, was the first iteration that we came up with, and that was very much more like a non-quantitative food frequency questionnaire where we asked people the foods they were consuming. This was the tool that was tested by Dr. Batubo that he presented upon in his first talk today. And it's what was originally given to clinicians. And what they told us in return is that this food frequency is great. I'm seeing what my patient is consuming in high quantities and low quantities, but it takes a while to scan and get through. So can you create something similar, but that's easier to interpret and quicker to interpret for myself when they come in and we sit down at our clinical appointment? So what we did from that is we created the Nigerian Dietary Risk Score, the NIDRS. And what that is that weighs all of the food components that we've looked at based on its association with hypertension risk. So foods that are more strongly associated and more predictive of hypertension risk are weighted more strongly. And foods that are protective, such as fruit and vegetables, are weighted negatively. So they'll actually bring down someone's score if they're consuming high amounts of that. So what the NIDRS is once that's completed, you simply multiply the frequency of consumption by a weight factor, depending on its association with hypertension. And at the end, we have a score that tells us the risk score of that person's likelihood of developing hypertension. So it's a much quicker way to summarize someone's risk of hypertension based on their diet.
Thank you so much, Dr. Michael. Dr. Batubo, you're free to, hop in on the call and answer some of the questions. We also have another question. What is the advantage of NIDR over the FFQ, the standard FFQ?
Sure. Yeah. So the NIDRS is quick and easy. That's really the best way to put it. For a health professional who's backed up and they don't have a lot of time to spend, they perhaps don't have the strongest understanding of appreciating the nuances of an individual's diet and just want to be able to provide them with quick and easy guidance, the NIDRS is the best. You can review it quickly, get a score on someone, see if they're high or low risk for hypertension based on their diet, and then provide feedback very quickly on where they could go in and improve that. Where the FFQ would come in handy, or where the Nigerian Dietary Risk Screening Tool would come in handy, is where an individual is really interested in providing either more personalized feedback on the explicit foods that an individual is consuming at either too high of quantities or too low of quantities and with certain frequencies, and have a more accurate understanding on the exact foods and how someone's diet is completely comprised, rather than the larger overarching food groups that someone is consuming. So for dietitian, a nutritionist, an FFQ could certainly, or the NiDST could certainly be of more value if there's time to sit down and talk to someone. But in a high turnover scenario, in a hospital office, or a very busy dietitian or nutritionist, an NIDRS may be the best way forward, and then perhaps an FFQ down the road to see how diet is changing and where it's changing.
Thank you so much, Dr. Michael.
If I could also go in, I saw someone comment on my spelling of the word dietitian. I've had the same feedback. I spell it two different ways because of my time in the UK, and then here in Canada, where I live, and then also in the US. And I do unfortunately go back and forth between my spellings, and I've often have colleagues correcting my spelling of the word dietitian depending on where it's being submitted to. So thank you for that. It's unintentional. It's just a habit that I haven't quite nipped in the bud yet.
Thank you so much, Dr. Michael. Thank you all for your questions, and thank you, Dr. Batubo and Dr. Michael, for your thoughtful answers and discussion. This is our last webinar for the year. Woo! But to stay updated with our events, you're excited. We are excited. We have an exciting lineup of webinars next year, and you will not want to miss any. So please subscribe to our newsletter and follow us on all social media. Also remember that you can replay this webinar. It will be available on our YouTube page at NDDI Africa in case you wish to go back to all these sessions. This concludes our 2-day webinar on exploring Nigerian dietary screening tools for research and policy. Thank you to our facilitators. Thank you again, Dr. Batubo and Dr. Michael, for your wonderful presentation. And to everyone who attended, we appreciate your participation, and we hope you found this webinar valuable. I look forward to seeing you next year in our future events. Good evening and goodbye.
Thank you.
Thank you.